Hey everybody, Ed Bowder from the Med School Medic podcast, medschoolmedic.com, here with your 5-minute EMS refresher. Today we're going to talk about some more pharmacology, and we're going to talk about a drug that's been getting a lot of attention, a lot of play lately. That's naloxone, or Narcan. So we know that Narcan is the trade name for this drug. The generic name is naloxone. You see it packaged over here on the screen. It comes generally in a Bristojet and a 2 milligram vial. There are some auto mucosal atomizers that have 4 milligrams in them. Just be aware of your dose. Some of them have 0.4 to 2 milligrams is generally the dose that you want to look for. And again, so most of the packaging has 2 milligrams per vial. So understand that Narcan or naloxone itself is an opioid antagonist. And what that means is that the drug itself is going to be a competitive antagonist against whatever opioid that patient has had. And generally what we're looking for is we're trying to block the mu receptors in the cell from the opiate itself. So here we have the chemical compositions of heroin and Narcan, and I know I'm not going to get too deep into the weeds as far as chemistry is concerned, because I know we all have forgotten organic chemistry at this point. But what I want you to realize is that each drug here have functional groups, and the functional group is what's really important here, right? So you see the drugs themselves are actually somewhat similarly constructed and aligned, but on the Narcan side, you're going to see that double-bound oxygen. What that's going to do is that's going to have a higher affinity for those mu, kappa, and delta receptors in the cell, and those are the big opiate receptors that we're looking to fill. So what happens is the patient takes an opiate, say it's heroin or morphine or oxycodone or whatever you may have. It's circulating through their system. We give them Narcan, and while that drug, the opiate, is still circulating through their system, what the Narcan is doing is it's going into the cell, competing for that receptor site, and once it binds to the site, the heroin or the morphine can't actually bind to that opiate receptor, and that's the important thing. That's what we're looking for. Imagine almost as you're playing catch. You throw the ball and someone catches it, you let it take the ball out of your glove, you throw it back to the person, you kind of rinse and repeat. That's how the drug itself works. So here we have this graphic representation of what we're looking at. So if you imagine the green being the Narcan and the blue being the opiate that you have, what's going to happen is the Narcan itself is going to find those mu, kappa, and delta receptors in the cell themselves. It's going to come in, and that double-bound oxygen is going to bind to the cell wall, right into that cell receptor. So it's kind of going to push the heroin or the oxycodone, the OxyContin, whatever they're taking, out of the way. So, and again, we want you to remember that you have this dose that's 0.4 to 2 milligrams is generally the dose that's accepted. And again, some of the automated nasal dispensers have about 4 milligrams per dose in it. I tend to think the 4 milligrams is a little bit high. There's plenty of evidence to show that 0.4 to 0.8 milligrams intranasally is perfectly effective for giving this drug. Intravenously, 0.4 milligrams might always be perfectly effective because, again, the idea of giving Narcan isn't to wake the patient up. We have this kind of weird concept that the idea is to wake the patient up after they've overdosed so that they can stay awake on the way to the hospital, and that's not the goal of giving Narcan. The whole point of giving a drug like Narcan or any opioid antagonist is to increase their respiratory drive. So what's going to happen is when this patient takes this opiate, their respiratory drive is going to start to be decreased, again, because of that binding that opiate has to all those different cell receptors. The patient's going to become bradypneic, they're going to start breathing slowly, or they're going to become apneic and not breathe at all. So aside from giving Narcan, we're going to have to give them oxygen in some way, and that's something that will be addressed in a different episode. But what we're looking for is we just want to get their respiratory drive up from whatever it is, whether it's 0, 2, 4, 6, up to about 12 to 16 breaths per minute, something that they're oxygenating appropriately. So this is another drug that you don't want to overdose them because of their overdose. We want to give enough, 0.4, 0.8 milligrams, that we can actually get them breathing again. Now, you may have some patients that take an exorbitant amount of opiates, so giving more Narcan might be necessary. The other thing I wanted to mention is what's called recidivism, which is after the patient takes Narcan, the half-life of the opiate is so long that it outlasts the Narcan. Usually doesn't happen. The half-life of heroin is about 6 to 7 minutes. When we start talking about carfentanil or acetylfentanyl, their half-lives are much longer, but really what we're looking for is to get the patient to breathe again while we have them. So we give them the Narcan. Narcan's half-life can be as up to 80 minutes, so that's really what we want to look for. We want to get them breathing again on the way to the emergency department so they can be managed long-term. That's your 5-minute EMS refresher. My name is Ed Bowder from the Med School Medic podcast, medschoolmedic.com. Be sure to like us on Facebook, follow us on Twitter and Instagram, and subscribe down below. Thanks so much.